Okay, so good morning, everybody. My name is Daniel De Backer. I'm the president of the European Society of Intensive Care Medicine, and I'm happy to welcome you to this webinar that will introduce the AMIBCourses course, Infection in the ICU, that will be held in September, next September in São Paulo. Today we will welcome Dr. Ignacio Martin Loches from Dublin, Ireland, and he will present us a webinar on less antibiotics. Marta?
Yeah, hello. Thank you very much, Daniel. So good morning to all of you. I'm delighted to have this webinar with all of our colleagues in the European Society and in Brazil. So, and we hope that we will have a successful meeting in September. So my task for today will be to present a lecture that is quite conflicting because in the days that we are talking now, we are using a lot of antibiotics. So I'm going to try to give another view that is called less antibiotics. But first, before going to these, we are going to talk more like less antibiotics because we are all living in this antibiotic stewardship era that maybe is more empirical antibiotic treatment for severe infections. So the first that I'm going to summarize is when we have a patient that is admitted to the ICU, we are going to have a mixture of two things. In one side, we are going to have the physician stress. So this is how we are facing a problem with our patients, and in the other, we are going to have the source of sepsis. We are going to talk, for example, about a patient with 38 years of age that is admitted to the hospital through the emergency department with a community-acquired pneumonia, and then we are very fast and we start treating the patient based on standards, so with antibiotic empirically, so based on different guidelines, we can use whichever we are using. But the problem is, at day 3, the patient is unfortunately not doing very well, and we have no isolates coming from the micro department, and we have to increase the spectrum of the antibiotics. So at day 5, some members of the team, we are starting to be more worried because this patient is with a severe ARDS, with a high FiO2 requirements, and the patient is more shocked, and we are talking about then more antifungals. So then at day 7, we start antifungals, maybe new antibiotics for covering more different spectrum, and then we eventually give some steroids. So the issue is that we are going to have two pathways. One pathway that is going to be the patient dies, but we have done everything that we could. We are very unlucky, and of course we are very sad to have a loss of this patient. And in the other hand, we can have a patient that survives, and this is a fungal infection, or could be because of the modulation of the immune response by the steroids. That actually is something that is difficult to really understand. So, but the problem is, which is the cause? Which is the cause of this strategy in our healthcare systems? And I think that this is part of the target of this lecture. We are thinking that this is science fiction, but this is actually something that it happens, and we have here one similar case. I'm sure that you had a case similar to the one that I presented, but we have a case in the New England, a patient in this case that is a little bit older, but same features, that we are giving more antibiotics, we are giving, we have negative spectrum, we are giving steroids. So, and the problem is, again, which is the cause of this strategy? Many of the things is because we don't have a good tool for predicting treatment failure in patients with sepsis. In this case was a community-acquired pneumonia, and in this study that we performed some years ago, we can see that many of the biomarkers that we are using in current clinical practice, some they are commercialized. In this particular study, we had a very good correlation with IL-6, that actually is one of the biomarkers that we don't use in clinical practice. This is the outline that I'm going to follow in the next 10-15 minutes. Why it's important to constrain the use of antibiotics, in which is the population, can we make it possible, and finally some remarks. And it's important because when we have an impact of MDR pathogens in our settings, we have in one side that we can have risk factors, and then we are going to give broad spectrum antibiotics. And at the same time, if we don't have the risk factors and we give broad spectrum, we are going to have two virtuous circles that they are going to be rounding all together. At the same time, we know that there is an increasing amount of antibiotic resistance. This is a very nice study that was published years ago in one of the good epidemiology journals, that we can see that the number of more resistant strains is rising over the last years. These are data from the US, but I think that these are data that can be totally comparable to the one in Europe, in South America, in Asia, or in Australia. And sometimes we are thinking that we need to do many new things, but I think that, in 2016, we are having mainly the same quotation that we had with Paul Ehrlich years ago, that the more antibiotics we give, the more resistance we are going to develop. However, it is important to define in which population we can do it. Because, of course, it's not the same when we have a patient that is very, very sick, that we have a patient with severe sepsis or septic shock, compared to ones that they are not shocked. And this is a nice study that showed that in patients with bacteremia, that they are patients that they are with septic shock and they receive inappropriate antibiotic treatment. As you see, the mortality is very, very severe. So for that reason, I would say that it's important to be sure how is the severity, because if the severity is very, very high, I think that we can go very hard, but if not, I think that it's important to wait and see how we can make it, of course, with some diagnosis help. So this is a study that we performed years ago that is coming with the Surviving Sepsis Campaign database, including more than 30,000 patients that was published in Critical Care Medicine. And that we can see is that when we analyze the patients that they have either severe sepsis or septic shock, we have patients that we have an advantage in survival within the first hour. This, when we try to analyze this only in patients with shock and independent of the organ involved for the source of the sepsis, we have similar results. But in one way, we have this problem. We have the problem of diagnosis, but we need a test. We need a test because not always to give antibiotics, is going to improve the mortality, but also we have other studies that they are showing that constraining the antibiotic therapy is not going to be associated with an increased mortality. We have two good examples that were published in the Blue Journal in 2000 and 2011, that with a more restrictive therapy, we had not only a decrease in mortality, but also a decrease in the length of a stay and the number of resistant strains. We know that we are living now in another era. Another definition of sepsis has came to the field, and because probably the SIRS criteria were not very adequate. And we know this, and I consider, and I would like to congratulate John Livingston for this fantastic paper that was published 20 years ago, showing the problems that we have with SIRS. However, we can see the glass half empty or half full, and this study is showing that we are seeing the glass half empty. In my opinion, this study shows something interesting, that in 1 out of 5 patients, we are not going to have adequate SIRS criteria. However, I would say that not only is like that, because we are going to detect with the SIRS criteria 80% of the patients that they are developing a sepsis. The debate is open, and of course we are going to, we need more prospective studies in order to see if these new definitions are helping for the clinical practice. Because we don't identify and we don't diagnose very well the infections. This is a study that was done in the Netherlands, and in this study that they include almost 9,000 episodes of ICU admission. 37% of the patients received antimicrobials, and when they did a post-hoc analysis in order to assess if the infection was present with a 4 definition process with known, possible, probable, or definitive, when after giving the antibiotics, we see that we fail quite often. However, I think that here we are going to see the glass half full, because if we analyze what's going on with patients with septic shock, we do less bad than if we have a patient that is less severe, like in a patient with sepsis. So for that reason, I think that, again, if we have a patient that is very, very sick, I think that to hit hard, to give antibiotics, it is important, but if the patient is not shocked, sometimes a wait-and-see attitude is totally perfect. We are, of course, different tools. We talk about different biomarkers, and this is just an example about a study of biomarkers that we can use in clinical practice, because many of them, I said IL-6, now we are talking about the inhibitor receptor for TNF and GCSF. We see that for back diagnosis was much better. So I think that probably to say to one biomarker, we might think about different use of maybe some biomarkers altogether. In this study, we use a good amount of biomarkers and we have a good correlation. However, as you can see, the CPAS is going to be a very good discrimination for the infection. So I think that the clinical practice is still something that is going to help. So how can we make possible, how we can decrease the amount of antibiotics? Of course, with these, I think that these are principles that I could like, and I consider that they are very important for us. I think that we said that we need rapid diagnosis. I think that the rapid diagnosis tests, they are still to come. I think that in the last 20 years, I think that we have been exploring a lot about a magic tool, a biomarker that is going to help us, and I think that we are still far from there, but there are some that they can help. We need to invest more, but I could say that probably our first investment could be in the next 10, 20 years for having a rapid diagnostic test. In the next days, I think that there are a few things that I think that they are important to consider. The first is that we don't need to treat colonization. Is not the same. Leukocytosis and infection and fever is not always showing that we have an infection in ICU. So I think that we have to keep all together many of these features when we are going to treat a patient. So, and there are some examples about what I said before, that we don't need to treat cultures. This is a study that was done almost 10 years ago, more than 10 years ago, that came from a kind of a hospital that is not very common in many, many countries. This is coming from America, from Lucy Palmer's group. And these are patients that they are receiving prolonged mechanical ventilation, a chronic respiratory failure. And in this patient, what is surprising is that, as you see, a good amount of these patients, they have high, very high numbers of bacteria in the airway. And it doesn't mean that the patient was going to require any antibiotic, because the patient was totally stable. So for that reason, one of the advice that I could say is that don't send a culture unless you are going to treat it. And I think that the best example for this is probably the isolation of Candida from airway samples. This is, again, a very nice study, and I think that this study changed a lot many of the clinical practice in many units, because in this study we have patients that they were dying in ICU with a high rate of autopsy. As you see, is almost 80%, and we can see that what they did is they match or they pair the isolation of Candida in respiratory samples, BAL or endotracheal aspirate, compared to a lack of isolation. And what they did is they analyzed the biopsies of these studies. We are talking, of course, about immunocompetent patients, and we can say with no fear that Candida pneumonia does not exist, and we have to double check when we are starting treatment for Candida isolated in the airway if we are doing the right thing. However, as we know, despite of the evidence, sometimes we doctors we are a little bit stubborn, and we want to, when we have a patient that is having a high burden of Candida in respiratory samples, we are always daring to give an antifungal therapy. This is a study that we did in Barcelona with Tony Torres, and in this study that we did analyze is the impact of treatment. So in these patients that they had Candida isolated and they were treated with antifungal therapy, how were they doing? The first that we can say is that we see that the predictors for Candida colonization were the classical ones, especially surgery, severity, and interestingly, diabetes mellitus. That is something that has been in and out in different studies, and that we can see is that the isolation of Candida in respiratory samples is not associated with a worse outcome, not only with the length of a stay, but also when we are taking into account the mortality. However, in this study that we did was we also incorporate a propensity score in order to analyze the impact of the antifungal therapy in the treatment, and did not show any difference. As you can see, the treatment of Candida in sputum is not going to change at all the outcome of our patients. More recently, a very nice study published in our journal in Intensive Care Medicine, we see that in this randomized trial with placebo and interventional arm giving broad spectrum antifungal therapy, in this case we see again that with echinocandin there were no difference in any of the outcomes, not only mortality but also length of stay. So how we can convince that is, we have many data that giving antibiotics is not adequate when they are not needed. I'm not saying that if a patient is in septic shock and is very severe and we have a query of an infection, we have always to give it. Another issue is when we have to start the antibiotics and for how long. And this is a model, this is a mathematical model. Of course, it's a mathematical model, it's not the reality, but I think that we have to congratulate to have this mathematical model to show how we are giving the antibiotics. They compare treatment on the ward, we are not talking in ICU, and how is the antibiotic pressure that the patients they can have when we start treatment on day 3 and we stop with a prolonged time on day 21, or the opposite, when we start on day 1 and we stop on day 8. And we can see in this slide in different colors, but you can see the number of resistant strains that you have the legend in the upper side of the slide. The number of resistant strains are totally different if you prolong the antibiotics compared to the ones that you start very early and you stop very early. So for that reason, we have to recommend again when we are going to give the antibiotics to also to take into account the time. So finally, there are other strategies that they need to be incorporated in our clinical practice. For instance, the use of prophylaxis in patients that they are they are comatose. In this study, we could demonstrate with a before and after study that just giving 1 dose of antibiotic, in this case was ceftriaxone, we could decrease the number of early BAP episodes because we can decrease the burden. So again, this is another explanation that we have to give the antibiotics early, but don't prolong over the time. So this is my last slide. It's just to try to summarize some key points that I consider that they are important. And I think that they are important when we are having a patient, if it's coming from the community, if it's coming from the hospital, or the patient is developing the infection in ICU. Of course, we have to review the current guidelines. I think that the guidelines are going to help, but we have to act locally. Of course, it's not the same depending on the hospital we are, because in some hospital we know very well how is going to be the ecology in our hospital. Of course, we have to take into account previous antibiotic use, the severity of the patient, as I said before, and of course, source control, especially for surgical patients that we know that the use of antibiotics without an adequate source control is not going to help. I think that also loading doses and the use of total drug monitoring in ICU is something that we need to incorporate, especially for those strains with high MICs, and we have to do a very close contact with microbiology in order to establish a good policy for de-escalation. And probably I could say for the vast majority of the patient, we can provide a short duration to 7 to 10 days, always based on the clinical progression. We can incorporate different biomarkers to see if the patient is doing better, and we can tailor the therapy, of course, with those when we are having an infection with known MDR pathogens or the MIC is low. And again, and I incorporate to have an adequate source control. During the Congress in Milano, we are going to talk a lot from the infection section and the sepsis section about source control, and I think that this is, in my opinion, one of the most important points. So with this, I would like to thanks to you, your attention, and thinking that in many occasions we don't need to look very modern, because you see this fantastic slide that we are talking about these years that selfies are very modern, but this is something that happened a long time ago, and there are sometimes time to go back to the basics. So thank you very much for your attention.
So thank you very much, Ignacio. I'm really eager to be in September to listen to more of your presentation and the presentation of the two other experts from ISICM, including, of course, Jean Chastre and Ricardo Ferrer, in addition to yourself, and of course also the several AMIB experts who will also present the talks and will discuss with the audience in a very interactive way this issue of infection in the ICU. With this, we all thank you for the participation, and we hope to see you in a large number in the Sao Paulo meeting, and more importantly, to have you very active and asking a lot of questions during the presentation, but also during the breaks. So thank you all for the participation.